Kalau gitu kan lebih baik. Ada. Itu sampai shalom Om Swastiastu, Namo Buddhaya. Morning, ladies and gentlemen. Good morning. First of all, let us first thanks to the Almighty God, because despite His protection, we can still get into safe, good condition. So, ladies and gentlemen, let me introduce myself. My name is Aurum Arsenius Sau. You can call me Aurum, and I'm studying representing Master of Ceremony in today's center. Okay, to take the advantage of time, let's continue to our main agenda. Our seminar today will be okay. The moderator of this seminar will be my friend Romana. She's the second year student in the Faculty of Medicine and Veterinary Medicine in our university, and she was an exchange student in the United States of America. So the ability of English is perfect. So, ladies and gentlemen, without any further ado, let the seminar begin. Romana, give it a go.
Good morning, ladies and gentlemen. Thank you all for introducing me. I'm Romana as today's moderator with our amazing speaker, Dr. Gillian, under the topic of psoriasis. Ladies and gentlemen, right in front of us, we have our speaker that we are so grateful for having the chance to learn from you, Dr. Gillian Marshman. Dr. Gill is a senior visiting dermatologist at Flinders Medical Center and Repatriation Hospital. He began visiting West Timor in 2005 to set up a program to upskill local healthcare professionals in skin diseases. Our academic interests and projects have included a collaborative project with the University of Undana Medical School, Johannes Hospital, and the Public Health Department, describing scabies prevalence in regional East Nusa Tenggara. Is currently assisting in the development of a database relating to leprosy. Dr. Gill has been involved in teaching medical students, junior doctors, other specialists, and mentoring doctors in the areas of recognition of skin disorders, effective treatment, and wider public issues of dermatological diseases in the community. She has been involved in supporting the development of multidisciplinary cancer service at Professor Johannes and is committed to engaging with doctors, nurses, and the community to improve access to effective healthcare at all levels in East Nusa Tenggara. Ideally, with programs based on sustainable healthcare through broader and targeted education, she will learn for herself as she does it in the next few years. Everyone, let's give a round of applause to our speaker, Dr. Julian. So Dr. Gio, our seminar session will be divided into parts. Firstly is we're going to hear from you, and the last session will be the Q&A session, which will be divided by some parts that I'm going to inform you. So Dr. Julian, with all due respect, and first.
Thank you. Well, come on. Thank you very much. It's such it just shows how long since we've been here with COVID. It was, very hard for everybody. And it's just so nice to be back. And I was delighted to hear now that we now have from Undana more than 400 medical graduates. So being here at the very beginning, it is enormously pleasurable for me to hear that news. So congratulations, you guys are doing a fabulous job. Psoriasis as to be 10th picture at a time. Unfortunately, I don't have a lot of pictures of skin, which I think is actually a problem for us because interpreting inflammation, particularly in darker skin colours, is actually. But we'll work through this and see how we go. Now, just tell me which year group you are, or is this various year groups? Second year? Okay, so you're not really in the space yet. Okay. Flinders University believed very early on in putting students into the clinics right from the word go, the beginning. When we first came to Undana, we kind of changed the idea here a little bit because we took first year students with us up to Kepamanan, and we put them in the operating theatre and the recovery and the outpatient triage, and there is a real benefit to that, but it's really hard to organise. So take absolutely as much opportunity as you can to be involved in clinical medicine as soon as you can. So I encourage you in that. Okay, so let's talk for a moment about psoriasis. So this is just a snapshot. I might sit down. Sorry. This is just a snapshot of psoriasis in Australia, but the numbers are probably very similar across most countries. So there is about a 2 to 3% prevalence of psoriasis, which translates to an awful lot of people if you think about it. And about a quarter of those patients have severe disease. So this is not small numbers that we're talking about. So if we look in Australia, we've got about 7% in the early 2000s. But the question is, what about severity? What is the cost to both patients and the community? And we know that children are affected as well. So this is just a couple of diagrams of impact psoriasis. So you might see these waterfall charts of impact of various diseases on people's health, and it's a bit like a table of severity. If you look at psoriasis, it's here, and I haven't got a pointer on this. Okay, so it's the dark one near the end. Now, healthy adults are up this end, and as you move along that axis, that is things like myocardial infarction, diabetes, and we're ahead of congestive heart failure. So psoriasis has a huge impact on people's health. It is not simply a skin disease, and we'll see why. And below that is the impact of psoriasis on people's mental health. So often people think that skin disease in English has the word just in front of it. It's only skin disease. It is not only skin disease, but people treat it like a cosmetic problem because you can see it. If you could see the same amount of inflammation in the lung or the liver, you wouldn't call that cosmetic. But because we see the skin, often skin disease is given less priority. But what we know now is inflammation involving the skin involves the whole body. And so you might see the skin involvement, but there's a lot of other things going on. So one of the problems is the quality of life impact of patients with skin disease on their mental health. Because lots of people around don't think it's really very important. So just be aware of that when you see people with any skin disease, actually. So, okay, what's going on in psoriasis? So, basic science is here. Now, for you guys, this probably looks like alphabet soup. Lots of numbers and names, but essentially we now understand that psoriasis is a disorder of immune dysregulation in the skin. Many years ago, people thought that psoriasis was just a problem of skin cells being overactive. And so if you could reduce that down, it would be fine. It's nothing like that. There is really very involved immunology, and skin cells talk to the immune system all the time. There is a cross-reactivity going on. Do we have a pointer? no pointer. I put the pointer on the here, but okay. I'll just walk you through it. This is the keratinocytes stem cells produce all by themselves interactions with the immune system, and the whole thing feeds forward so that by B cell and T cell activation occurs. You guys know about B's and T's, immune cell activation? Don't ring any bells? Oh, I'm getting some yeses and some no's. So the problem is systems where you activate one part of it, which then causes, like dominoes falling over, a whole lot of other things to happen. And we now know that all of these, like interferons, cytokines, drive both the inflammation or the redness you see in skin, but also the proliferation of the skin cells themselves. So it's very complex. And now in medicine, in lots of areas, we can target those particular cytokines made in inflammation and take them out of the equation. So you will hear about this in inflammatory bowel disease, in rheumatoid arthritis, in psoriasis, even uveitis. So autoimmune disorders where you can regulate or try to bring back to normal that imbalance. So what this just shows you is the complexity of what happens in skin inflammation. So when you look at a biopsy of skin with psoriasis, and you will learn, presumably, to look down the microscope and see things, pathology, do some pathology. Okay. So what you see is you see thickening of the top part of the skin called parakeratosis. This odd elongation of this is the epidermis, top part of the skin, this is the dermis. You guys know that? Yeah, okay. Sorry, I made it too simplistic, but normally the epidermis sort of looks like that, and in psoriasis it's much bigger, it's elongated. And you get scale towards the top, and you get some thinning of the capillaries as well. And then you also get an infiltrated polymorphs into the top part of the skin. You get some changes in the normal way the skin develops, so it becomes much more fragile, even though it's thicker, and that dilatation makes it look red. And that then is what that inflammatory cascade produces. So just in terms of epidemiology, we know it's about 50% of the population. Any age can get psoriasis. There may be peaks when it comes on, but you can get it when you're 2 months old or when you're 99. The childhood onset is often associated with infections like streptococcus throat infection, but there are often other things. We know there is a condition, so there may be in place. The natural course of psoriasis is inflammatory waxing and waning. So it comes and it goes, or it gets better and then it gets much. Now, which one do I press so that I got top one? Yeah. Oh, thank you. So that it tends to improve sometimes, but then other triggers make it worse. So the clinical features of psoriasis are really well defined. So this is what we're looking for. They're usually well-defined red plaques of skin. So it is an area that often looks like this, all joined up. There's a scale associated with it, which is that abnormal top part of the stratum corneum. And it will occur in common sites like the knees and the elbows or the extensive surfaces, but also in other sites like the scalp in the flexures, so under the arms, under the breast, and it involves the nail as well. Patients with psoriasis do not have an increased risk of skin infection. So this is quite different to dermatitis where they do, but this is not an infection problem. And they're usually not as itchy as patients with eczema or dermatitis. So the scalp involvement is really quite characteristic, and sometimes that's all you'll see. So, oh, sorry. That it's often where you pick it up, or just in the ear canal, and the nail changes is this weird pitting. So it looks like somebody has got a little pin and gone along the nail plate and gone like that. And that's because the cells that make up nails are keratinocytes and they don't stick properly as they're coming out with the nail growth because they're abnormal. So they fall out. So what gives you thick skin in psoriasis, those abnormal top cell layers, is the same thing that gives you the pits in the nail. And then the other thing you will sometimes see is this thing called onycholysis. So in English, onycho is nail and lysis means split. So what happens is the nail splits off the bed of the finger. So it lifts and you see this change that looks like the nail's about off. So that's called onycholysis. But there are variants of psoriasis as well. So it's not always the very typical features that you see. So in children, it's often tiny little spots that occur all at once, triggered by something like a throat infection. Sometimes in the flexures, so the groin and under the breast in the axilla, because really moist environment, you often don't see the scale. The scale disappears, but what you see is the redness, and it's really well demarcated. There's a pustular form that occurs on the hands and feet, and there's genital involvement as well. Now, that is often a subject that is really sensitive for patients, and frequently patients will think they've got a sexually transmitted disease. So they'll present late, they'll present embarrassed, and they'll think that they've got other problems as well. But it's actually very easy to treat genital psoriasis. But there is a big overload of emotional involvement. So some more clinical features. This is really extensive psoriasis, and so is this, but you can see how thick skin in here is with that big scale you see. But it can involve the palms as well. And what happens often then is that it cracks. Now, if anybody has ever had a cracked heel here, yeah, it's sore, yeah. Imagine if that was on your feet as well. You cannot walk and you cannot work. So thick psoriasis involving the hands and feet is really disabling, not just indolent. And then involvement in the scalp can be really quite thick and severe as well. And in this patient with really bad psoriasis, sometimes what happens is it becomes almost the whole skin. And we call that in English erythroderma, which basically means red, erythroderma, skin. And patients, when they're acutely erythrodermic, look like they've been boiled. They're red and they're sick because their skin's not working the way it should be. So the function of the skin is a lot. It's to look after temperature and fluid balance and stop you getting infections and regulate immune system. So when it fails in this sort of situation, it's like having respiratory failure or renal failure or cardiac failure. There's a lot of other consequences. And likewise, you can get very nasty psoriasis affecting the palms in this situation when patients are severely affected. And it looks like pus. So lots and lots of areas of pus, but what's pus made up of? Anyone want to shout something out? No. Don't be frightened. It's made up of neutrophils primarily. So white cells. Now, you may or may not have infection to produce pus, but you can get pus that is not infected. It's just lots and lots of inflammatory cells. And that's what's going on here. So this is not infection. This is pustular psoriasis. So what about things that make psoriasis worse? Well, we know that all of these things in the list are important. And for some patients, particularly children, infection is important, but so is trauma. So this patient's had a tattoo, and what's happened is everywhere the skin's been traumatised, their psoriasis has come up in those areas. So trauma can be mechanical, like falling over, or it can be a burn, or it can be a natural remedy that's really irritating. So a lot of things can actually produce that. And then we know that alcohol is real. Smoking makes it worse. Obesity comes into some other issues in a minute as well. But also the kind of climate you're in. So in Adelaide, in South Australia, where I come from, it can be very cold. And cold makes your skin get dry and irritated. Everybody talks about stress and psoriasis. So if you Google psoriasis, first thing that will come up is it's all about stress. Actually, it's only 10% of patients for whom stress is an issue. So that's 90% of whom it's not. And patients often think it's all about stress. So really importantly now, if we go back 20 years, your colleagues who are now specialists would not have learnt about these problems. And these are the associated conditions of psoriasis. So this is where we recognise psoriasis is not skin alone. So there is a significant association with arthritis, with inflammatory bowel disease, with depression and anxiety, with non-alcoholic fatty liver disease, and with metabolic syndrome. So if you look at this graph, this is controls in red, and this is the patients with psoriasis. And you can see that metabolic syndrome, hypertension, lipid abnormalities, obesity, and diabetes are all dramatically associated with psoriasis. And that's a really important thing to recognise, because if you are the doctor that diagnoses the psoriasis, then you should be looking for these things as well. And then it gets worse in a way, because cardiovascular disease is overrepresented in patients with psoriasis. So if you have psoriasis, it's an independent risk factor for atherosclerosis. So whether you smoke or not, whether you've got a family history or not, whether you've got diabetes or not, just having psoriasis alone increases your risk of coronary artery disease. And the severity of the psoriasis increases your risk of myocardial infarction. We know that patients who have severe psoriasis have a similar 10-year risk of coronary heart disease and stroke. Compared to the general population, 28% greater and 11% greater for stroke. It's a really significant risk. It's nearly as bad as being a smoker alone. The other thing that we know about is chronic inflammatory psoriasis is associated with psoriatic arthritis. Has anyone heard of psoriatic arthritis? You heard of rheumatoid arthritis? Any arthritis? Yeah. A lot of people get what's called wear and tear arthritis. Hard work, you know. That's different. This is inflammatory arthritis driven by dysregulation of the inflammatory system. And in patients who have psoriasis, anywhere up to 25 to 30% now may have psoriatic arthritis as well. And it can be extremely destructive. And there is an increased risk of mortality in those patients as well. Unfortunately, the diagnosis is often late. So trying to treat this, try to treat early because it can destroy the joints. And if you look here, we're saying, why do we bother to treat psoriasis? Isn't it just skin? So we've got this sort of problem of severe, this is called exfoliative psoriasis, where the skin is shedding, like you've been burnt over and over. This is the arthritis, and you can see the deforming changes in the joints. And in young patients, it can come on quite early on. That's the severity that we talked about, but we now understand that the comorbidities and the life expectancy are really important as well. So how can you treat psoriasis? Probably in most instances, the average patient is going to be using creams, and that can be topical steroids, which are very helpful, or topical vitamin D preparations. Now, not all of these are going to be available here, but the steroids are useful to settle inflammation, but they also have some problems that they thin the skin. There are topical preparations with tar. You think tar, like bitumen, like roads? How is that going to help? So tar has an anti-inflammatory effect on the skin, and it can help lift the scale. So if you go to the apothec, you may see some shampoos with tar. Maybe not that name, but there are tar shampoos here in NGT. But the problem is, it's not very nice to use. It stains everything. It's not nice for your clothes. So it's hard to get patients to use it. So it wouldn't surprise you to hear that a lot of patients with psoriasis start treating with traditional remedies. And unfortunately, many of them irritate the skin and actually make things worse. So the factors affecting how you treat these diseases, the patient is more interested in, can I use this and people won't know I've got it on my skin? Is it cheap and does it work? The doctor is more interested in, does it work? Is it safe? And then which type am I going to use in which area? And tend to forget about the impact on the patient themselves, because if the patients don't like the cream, they won't use it. In Australia, we have phototherapy, which is using part of the wavelengths of ultraviolet light to treat psoriasis. Now, you don't have access to phototherapy here, but you have that stuff out there. You have sunlight. And sunlight for a lot of patients is actually quite helpful. But you mustn't get burnt if you've got psoriasis, because then that's trauma to the skin and it stirs it all up again. But careful use of sun exposure early in the day, late in the day, can help patients with psoriasis quite a lot. Unfortunately, long-term sun exposure has other problems. Skin cancer. And skin cancer occurs in NGT, believe me. So you have to be very careful about this. So the principles of how you treat psoriasis relate to where on the body it is, making it cosmetically acceptable, making it cheap. People won't use it, they have to pay a lot of money, and making it safe. But there are forms of psoriasis that you have to be really careful with. So when you see those pustules, those lakes of neutrophils, or when you see the boiled lobster, red, sore, unwell patient, you have to be very careful how you treat them. So there are other treatments available, and in NGT, probably the one that would be used most is methotrexate. So methotrexate is an anti-inflammatory drug, and it's used in much higher doses for cancer treatment, but that's not what you use it in psoriasis for. It has this anti-inflammatory effect, psoriasis, but it is not without some problems. And it can cause liver damage if you're not careful. It can drop people's white counts in particular. And it's really confusing for patients because this drug you only take once a week. If you take it every day, you will ablate your bone marrow. Gone. So that's disastrous. The other problem is you have to monitor with blood tests. And I think we all know it's difficult to get patients, particularly poorer patients, to have multiple blood tests. So you may not know what's going on. So there are some significant restrictions, but it's actually a drug that's very good for the arthritis as well. So in specialists, it is a really good option. The other drugs like cyclosporin and mycophenolate, learn about this, immune suppressing drugs. Used a lot in autoimmune diseases like lupus, perhaps, or in Australia in transplant patients, but they have a lot of problems associated with them as well. So arthritis is good for methotrexate treatment, but you have to be careful of these other problems. And unfortunately, you should not use methotrexate in pregnancy. It will induce abortion. So that's not an option. Acitretin is a vitamin A derivative drug, but unfortunately is very difficult to get here and also can cause birth defects. The immunosuppressants you will probably see in certainly your prescribing lifetime, but difficult to get at the moment. And then this is what you will read about in the medical literature, but it's not here yet. These are biologic drugs and they target those individual single cytokine inflammatory molecules that drive the whole process. These are very new medications, only in the last 10 years or so. They're extraordinarily expensive. So unfortunately, we're not going to see them in NGT anytime soon. But there are some oral versions coming. And you guys will be at the forefront of understanding how inflammation works in lots of systems because of these drugs. So just finally, how do you treat patients with psoriasis? Well, first of all, you have to recognise the disease. So those clinical features of a rash with really well demarcated red scaly plaques, often elbows, knees, scalp, nail changes, changes elsewhere perhaps like coexistent arthritis. So you recognise the disease and then you recognise the impact of the disease on patients. Because if you are sympathetic to the patients and explain that you realise this is not an easy thing to live with and it affects patients' quality of life, you are much more likely to have a longer term relationship with that patient who will then take your advice. And then it's a matter of what you are treating. Are you treating skin? Are you treating joints? Are you treating nerves? But remember, you're actually probably also treating comorbidities. So the data suggests that if you can switch off the inflammation in the skin, maybe you can switch off the inflammation in the blood vessels, leading to atherosclerosis and heart disease, peripheral vascular disease, renal disease. If you treat the metabolic components, so the fatty liver, the high lipids, the predisposition to diabetes, you have a huge impact on people's not only longevity, but the quality of their life. So aims of therapy, this is what we're actually trying to get rid of the visual and inflammatory signs of psoriasis. And it's really hard. But the newer treatments are giving us the opportunity to do that. So in summary, there is a really big problem of psoriasis and it will be quite prevalent in NTT. I've seen a lot of patients with psoriasis here. We know kind of what's going on with the pathophysiology, that really complicated inflammatory soup and the inflammation that talks between skin and the immune system. And we now know that there are a lot of other associated conditions that are not silent, but we should be looking for in psoriasis. And then we've got to think about our options. And for you in the future, it will be where do the newer biologic agents fit? Because they will become available and you will be using them. Remember, there are a large number of patients with this disease. It is a complex autoimmune disorder. There are lots of associations and there are lots of treatments, quite a lot of which don't work. So if your patients get onto their phone and search treatments for psoriasis, there will be hundreds of things offered to them, quite expensive no doubt, with no evidence that they work. So that's one of the most important jobs you can have, is to educate your patients as well. And then finally, remember, whatever we use to treat things, there are going to be potential risks and side effects, but it's about balancing that risk versus benefit and getting access for people to be able to use these treatments is really important. So that's where you, as their doctors, act as an advocate. So the rector this morning was talking about it's fine to have a degree, even a professorial position, but if you're not impacting the health issues of your community, then it is a fairly hollow credential. So I would just leave you with the idea that one of the most important things when you have the opportunity is to be able to explain to patients what's happening, that this is not something that we don't want to treat, and importantly, to give them this. And hopefully you can read that, it says hope. Okay, we'll leave it there, and I'm happy to take you. Yes, sure.
All right, thank you, Dr. Jill, for that very informative sharing with us. We're so grateful for having you as our speaker here. And as I mentioned before, we're going to move with our Q&A session, which means we'll take the first three questions. So any of you, if you have any other questions, just feel free to raise your hand and introduce yourself and quickly get your question. And as Dr. Jill said, that if she spoke too fast, you can kindly inform her to speak slower. All right? The first three questions, if you have any question, just feel free to raise your hand. Anyone? No one?
Yeah.
Okay, I have a question right there. All right.
Hey, thank you for the opportunity. First of all, my name is Florence. Thank you, Doctor, for the presentation. That is very informative for us. Sorry, I'm very nervous. Question. The first one is, let's say that there's a patient that comes to us, and well, we recognize all the clinical manifestations, such as rash and the thickness of the skin and the and others like the first the big how do I say the first step of the, let's say, psoriasis,
Sorry,
the first stage.
first day?
Yeah.
Yeah.
So we recognize it as maybe autoimmune disease. But in Indonesia, we have also health regulations, so we can directly treat the patient as psoriasis. So how do we manage to have a definitive diagnosis? Is it we can directly to ask the patient for a lab test or some kind of autoimmune disease or anything? And how, as you may say before, that there's a large number that it's too late to treat and it become more complex. It's the patient has more complications such as metabolic disease and heart disease, and also can cause the psoriasis arthritis.
Yeah.
As you say before, that it may come too late to treat the disease and how to prevent it, because we cannot in class to diagnose the autoimmune disease. It's more complex than that. And how is that? As to doctor to diagnose by the clinical manifestation. And the second question.
Oh, that's a lot. Thank you.
This
Take
second,
it right from now. Yep. I'm listening. Okay.
second question. In the beginning, you say that there might be a difference for the people of color. So I want to ask, is there a significant difference between the fair and darker skin for the psoriasis clinical? Oh, fine, thank you.
Okay. Which one is it?
All right, thank you. Dr. Gil, do you want to direct the answer or should we wait for one other question? One other question, so we'll make it
We're gonna
brief.
do it as we go. What did the director say? That you get things when you get a little bit older?
Yeah.
First one. I might answer this second part first. So when you read textbooks about skin disease, many of them are written for Anglo-Celtic skin types. All the pictures that you will see in the big textbooks are often of skin colour like me. And so the discussion is often about erythema or redness. Redness in darker skin and colour is actually quite difficult to pick. And often, in fact, what you see is grey colour. So instead of a lighter brown or brown colour, there is a grey discoloration in the area of inflammation. And the darker that is, the more intense the inflammation. Sometimes you'll see some redness around the outside, depending on somebody's skin type, but you may not see redness alone. And in fact, for us in Australia, we have a very diverse population and we are very slow to appreciate that not everybody meet. And so as even specialists, it's taken us a long time to understand how skin disease can present differently. But if you think of a greyness scale rather than a redness scale, particularly for chronic disease, it can be quite helpful. You will still see scale, you'll still see thickness, but often that can be quite dark. So in skin of colour, what tends to happen when the skin is inflamed, you'll also get a lot of post-inflammation pigmentation change, or post-inflammatory hyperpigmentation. So there will be brown or darker marks where the skin disease has been. So that is important to recognise, and I suspect that you will be much better at it than we have been at home. But it's really important to understand that because it's much harder to actually diagnose. But the distribution is the same, the scale is the same, the pustules when they occur are the same. So those features clinically are still present, but the redness might be quite difficult. That answer the question? No. Now, the first question, I think, could you summarise that for me? I think it was about diagnosis and then, yeah. So, with the regulations in Indonesia for treatment, I think certainly the simpler treatments can be used in the puskesmas. So you can action to get topical steroids, to get the tar products, to get the shampoos, things like that. For the oral medications, there may need to be a referral to a specialist or a physician, but often the GPs in the puskesmas still are involved in monitoring those patients as first port of call. So my understanding is for patients here, they have to go through the district or puskesmas, the district hospital, to then get referred on to see a specialist. So this is a problem of access to people with more information. That doesn't mean that if you're the doctor in the puskesmas or the district hospital, you can't ring your colleague who you went through medical school with, who is now a dermatologist, and say, what do I do? So one of the most important things you learn as you progress through your education is how important communicating to your colleagues in a multidisciplinary way can be. So sometimes the system doesn't work very well for the patients, but you can be the one that gets on the phone and says, help. And this is a very important medical tool. If the patient agrees, you can send a photo to your senior doctor or your specialist and say, help me. Okay? That sort of answer. In terms of preventing the comorbidities and the arthritis thing is really hard because often the arthritis comes later after the development of the skin disease, but people don't recognise the association. So you have to examine the joints when you examine the patient. And sometimes it's things like toes, so they have to take the shoes off, you have to have a good look, and hands as well. Treating with topicals doesn't affect the arthritis, so you have to treat with the oral agents to get control. So that's where you get a physician involved. That answer?
Does that answer?
Yeah. Anyone else? You're either stunned silence or very quiet. I'm not sure at the moment how much dermatology you now have in the curriculum. When I was here a little while ago, the final year students who come to the clinic were very good, probably better than our students. But often skin disease gets only this much in your teaching, yeah? Only a little bit. So when you are doing your clinical years, I would encourage you to take the time when you're examining your patients to actually start with their skin, because the skin can be a real window into people's health, and you will learn later on about a whole lot of other conditions, internal conditions that present with changes in the skin. So psoriasis is one of them, but there's an awful lot of other ones. And if you are smart, you can pick it up by looking at patients' skin as well as listening to their heart and listening to their lungs. So try to read a little bit more about skin disease, and there's good stuff on the net now, which hopefully you guys can access. But your curriculum is actually really very good. It's just you don't get enough.
All right, I'll be waiting for my friends their questions, but I personally have two questions. Firstly, because you mentioned that psoriasis can happen to everyone, anyone, adult or be children. And therefore, if you look considering the differences between children and adults, they are different between their characterization and etc. So how do we differentiate ourselves from treating these children patients with those adult patients? That's the first question. And the second question is about associated conditions, say it's psoriasis, arthritis. What should we prioritize first to be treated? The psoriasis or the arthritis, or we can treat both at the same time? Thank you.
Okay, they're really excellent questions. And in fact, with the second one, that's a real struggle. So sometimes what will happen is in the community doctors will think the skin disease is not as important as the arthritis.
Yeah.
If you ask the patients, interestingly, they will often say they want the skin fixed first and then the arthritis. So there is a bit of a disconnect between our expectations and somebody else's. So that's really important. If you can treat skin disease early, perhaps you can stop the progression of those other diseases. Now, we don't have proof of that yet, but these new biologic drugs can do that. And there's just starting to be some evidence that if you wipe out the skin disease, you stop those other longer term problems, which is kind of like revolutionary. There are medications that will treat both. So things like methotrexate have a role, but it's these newer generation drugs that are going to make the difference because they are so targeted. And there will come a time when you guys get access to these in your medical lifetime. Not right now, but later on for sure. In terms of presentations in different age groups, so in children, you may see psoriasis in babies and it will be misdiagnosed as napkin dermatitis, so nappy rash. That means something to you guys?
Yeah.
Yep. So sometimes it's a diagnosis that is made, what we say in English, retrospectively. So a baby's been treated as nappy rash, but in fact, over time, they evolve the features of psoriasis. And there's a trick with little babies and nappy rash that psoriasis is so well demarcated. It's like someone's got a pen and just drawn around it. Pure nappy rash is often a little bit more diffuse and it will often not have any associated features outside of the nappy area, whereas even in littlies, they may start to have bad scalp seborrheic dermatitis, cradle cap, except it's not cradle cap, it's psoriasis. And so some of those tricky areas that you can look at, like behind the ears, into the scalp areas, and there's a really interesting area, which you wouldn't pick, but it's the umbilicus. So if you look in the umbilicus and you find a red, slightly scaly, persistent rash, that may well be psoriasis. In many children, their first episode of psoriasis, though, is the one precipitated by an infection. So they've had a sore throat, they've had gastro, they've had some, and the pattern of the psoriasis is difficult because in English it's called guttate psoriasis. So guttate actually means like a teardrop, like a raindrop. So instead of really quite large localized areas, say on the elbows or the knees, what they get is a whole lot of these showers of tiny little areas of redness and scaling. And they crop. So they get one lot and then another week later they get another lot, but it's widespread. So it is a different pattern, but from that they may evolve into the adult pattern quite quickly. Oh, we've gone quiet. Okay, let me ask you a question, and I'm not Janine, but if you were looking at a patient who has psoriasis, you have to sort of go through the process of diagnosing what else could this be. So are there any ideas about what else might look a little bit like psoriasis? Just shout out. Would eczema or dermatitis look like psoriasis?
Yes.
Maybe, yeah, it can. But eczema tends to be nowhere near as well demarcated, so it doesn't have that really obvious change between affected skin and unaffected skin. So psoriasis, you can tell absolutely where the edge is. Eczema, it's often much more runs off, can't tell where it is. In the groin or the flexures, the other thing to think about is tinea, so fungal infection or candidiasis. So they will occur in those areas with redness as well, but often not that really well demarcated edge. So if you see a really well demarcated edge and it's got scale, think psoriasis, but it could also be a tinea. You've been very long suffering.
Do we have another question? One or two?
Oh, and get that bit. We'll pounce and what's the music?
Okay, thank you for the opportunity. Yes. I think it's very bad actually.
Bad.
What I know, psoriasis can cure one from existence. That is the sign of mental problems.
Hang on, I can't quite hear you with your mask. You might have to tell me what you're saying.
Okay.
Yeah, take it.
Thank you for that. Thank you for the opportunity. When I know psoriasis, it cannot be cured. One factor is stress. Stress is a mental health problem. I'm quite interested in mental issues. Actually, however, when one has psoriasis, it increases mental problems. I would like to ask from the experts, doctors, how steps are being taken to address mental problems in people with psoriasis and whether they can be applied in Indonesia?
Yeah.
And let's have a questions and discussions. Okay, what I can say, psoriasis is not be contagious.
Yeah.
The report acknowledges that it captures psoriasis genital.
Yep.
People with psoriasis, they do not have a high risk of infection. So those with psoriasis can become genital transmission agent to this partner. My question is, how do people with psoriasis genital produce springs of child? What educational step do doctors need to perform? Thank you.
All really good questions, and I think it's great looking outside of just the problem of diagnosis. I might start with the second bit first. So, straight. Genital psoriasis has no problem associated with infection. So you do not pass genital psoriasis to your partner, nor do you have a higher rate of getting infection of other types in genital psoriatic skin. So the problem is that the patients will often think that this is an infection because of where it is. And by the nature of human beings, will be very worried that it's a sexually transmitted disease. So it's really important to be able to reassure patients that this is not an infection and their partners, because the relationship issues can be significant. There is no fertility issue if you have genital psoriasis. It does not change your ability to have children if you are either male to be father or female to be mother. It does not have an impact on the outcome of a pregnancy. However, if the patient has very severe psoriasis, like pustular psoriasis all over, or erythroderma, that has an effect on the mother's general health, which has a secondary effect on the growth of the baby. So in fact, having really bad psoriasis during pregnancy is something we should address with treatment if at all possible, because it can produce smaller babies in patients who have very bad disease. The other problem is that a lot of patients with severe psoriasis may also have metabolic abnormalities and be prone to diabetes. So if you are prone to diabetes and fall pregnant, you may be prone to gestational diabetes, which has a significant outcome on the health of both the mother and the baby. So no, it's not an infection. You can't spread it and you're not at greater risk of infection, but certainly it has a huge impact on people, both emotionally and sometimes physically. So you as young doctors will be able to address some of the misinformation that's out there when it comes to diseases like this, because it will all be on the internet that this is, terrible disease that you can spread. Not so. So being well informed and being able to explain that to patients is really important. The larger problem of mental health issues in patients with chronic skin disease is really important. And what that chart showed you is that it has a high impact on people to have psoriasis. So I remember a patient that I had, that I still see, whose family thought that her psoriasis was an infection, and so they never hugged her. Can you imagine growing up and your parents don't give you a hug, or your sister doesn't because they're frightened they're going to catch something? So that is a horrible thing to happen over a lifetime. So being able to treat her psoriasis really aggressively and control it has had a huge impact on her mental health. But we know that the problem of the way the community sees skin disease is so often it's an infection. The child with psoriasis who the parents of the other children don't want them to go in the pool, in the swimming pool, because they might spread it to their children, or hold their hand at school when they're tiny. So those things last in people's memories. And we know that patients with psoriasis as adults have a much higher increased risk of depression and anxiety and often substance abuse, alcohol, smoking, and sometimes other drugs as well, which they may not admit to. So the impact is real and it's significant. The first step is to recognise that as being their treating doctor and not dismiss their disease, because just about everybody else around them will have. So you are the person that finally validates, validates in English? Validates. I don't know what is the bahasa for validates. Validates. Yeah, okay. So you're the person that says you have every right to feel distressed by this disease. It's real. It's not just something that's a nuisance. And that can be very important and empowering for patients to have someone say, I understand. That really is very important. In terms of control of disease, if you get good control, you can stop a lot of those flares. So that instead of doing this all the time, it's doing that. And that's really important. And there is now evidence that if you use some of these newer medications, you can switch it off, but they have to stay on treatment. There is some evidence that in children with bad psoriasis, you can, if you get in early enough, flip their immune system and, in inverted commas, cure them. Now, that's very early days yet, but that looks like it might be true. And certainly you might be able to stop the development of the arthritis. So I think you'll see a huge change in your lifetime in the next few years as young doctors in how we treat these sorts of inflammatory diseases. But recognising the impact on the person, we are treating people, not just their skin. Nothing else? What?
Thank you for the opportunity. My name is Jessie. Thank you for your explanation. That's really great for us. So I have two questions. First of all, you told us that the exacerbation risk could be beside trauma and so like alcohol smoking, and so you say it could be a. So what I just think, that in like we as a female, as a woman, like our hormonal is more like complicated, like more than men.
Yeah.
So yeah, much more. So like how hormonal could give a lot of impact for this psoriasis exacerbation? Like that's the first of all, and like which one? Which hormone? Yeah, so that's the first one, and like the second is you said that let's say the differential diagnosis of this psoriasis could be a tinea, right? That and like as I've learned, like tinea capitis are maybe I'm sorry if I said it wrong. Okay, so tinea capitis, yeah, it casts, if I'm not wrong, it casts for because of infected for tinea capitis, but for psoriasis, it's not. This is not an infected disease. So, like, if we have a patient, like, they come to us, and then we see like it's happened in their head. Like, yeah, we could think that it be psoriasis or tinea, right?
Yep.
So, like, what should we do? Like, we take the tissues and we see from microscope or something like that. Or like what should we do if we really wonder, or we can't take a lot of differences between tinea and psoriasis because like it's in his or her. So what should we do? That's all for me. Thank you.
All great questions. So I'll start with the hormonal thing. So a lot of female patients will tell you their skin disease of various types flares with their cycle. So it may well be more progestogens than estrogens that drive this, but it's certainly not well delineated. And I shouldn't make you think that it's really common that hormones play a role for women with psoriasis, but there's a small group who do seem to flare just before their menstrual period. So there might be some argument to try and control that better, but it's only a very small group. So it is probably more important to understand perhaps the role of pregnancy hormonally in patients with psoriasis, because if you think about it, when a woman is pregnant, baby is only half genetically her, right?
Yeah.
So how come you don't reject the baby? Something must happen to your immune system. And what happens is you often end up in a state of relative immune suppression. So there's a change in the reactivity of your immune system when you're pregnant. If you have an autoimmune or inflammatory disease, sometimes it gets better during pregnancy. And we talk about the rule of 30%. About 30% of patients get better, about 30% stay the same, and 30% actually get worse. So that's telling us that their balance of their immune system is different. The issue for patients with psoriasis in pregnancy is often after they deliver. So if during pregnancy their psoriasis gets better, for many women in that circumstance, once they've had the baby, their psoriasis flares. So things can flare to where they were before, or they can actually do what we call a rebound. So it's like bouncing a ball. You know, not only does it come back to where it was, it actually gets worse. So being aware of that can be really important as well. But I think being able to state categorically that changing somebody's hormonal cycle is going to help their psoriasis is not likely. But a few women will tell you that it does change in the cycle. In terms of the other question, that was a really relevant and sensible question. How do you tell if a child who has a scaly scalp has psoriasis or tinea? So tinea in the scalp in children can be quite severe. And if it is a tinea or a fungal infection that has come from an animal, so fungal infections can come from another person, they can come from the soil, or they can come from animals. If it's come from an animal, it's often inducing a very inflammatory reaction in the skin, because your skin immune system says, hang on a minute, I haven't seen this before, this is foreign, let's attack it. So in children with animal tenues in the scalp, they get a lot of hair loss, they get a lot of inflammation, it looks infected, it's pussy and tender and what we call boggy, so it's quite raised up. They're the easy ones because you can diagnose that as a tinea infection quite easily, and you can look at the hairs down the microscope and ask the laboratory to do that, or even culture. But that's not so difficult, that one. The child that just has some scaling in the scalp, you look elsewhere for signs of tinea somewhere else. So feet is important because that could be where they've got it, and nails. Check the nails as well. And then look for the other features of psoriasis. So involvement in the ear is usually not tinea. If you can see scaling in the ear or just behind the ear, that's very rare to be fungal or tinea. And the other thing is the distribution. So psoriasis in the scalp is usually around the frontal hairline or at the back, just there. It's not usually all over. So if it's all over and it's fine scale, it's probably not psoriasis. It may be dermatitis or it might be tinea, but it's probably not psoriasis. So psoriasis has this very silvery looking scale to it. It's not greasy and thick. And then it's the distribution of any other psoriasis elsewhere. So you have to make a clinical diagnosis in the first instance. If you really think it's tinea, treat the tinea first. It won't fix the psoriasis. Thank you.
All right, everyone, we have now. Do we have other questions or any other questions? One or two? Or are we good with 8 questions? Yes. Okay, we have some questions over there. For your opportunity to be.
Thank you.
First of all, I want to say thank you to Dr. Gillian for being here and giving us a very nice lecture. I want to ask about
mentioned before, the PowerPoint mentioned that psoriasis has correlation with increase of risk in coronary heart disease and also stroke. Question is, I want to know how can this psoriasis can be associated with coronary heart disease and stroke. And also, I want to ask about therapy. That we can also give the food therapy for the psoriasis patient. This therapy is also can interest with skin cancer patient. So how can we can still have this treatment while we also prevent this the skin cancer? And that's all my question.
Great question. So, people actually must have been listening. That's fabulous. Okay, so, okay.
Okay, thank you for the opportunity. My name is Tanggal.
If you shout, I can hear you, I'm sure, and probably the others can. Yeah.
Does everyone who has metabolic syndrome can get psoriasis, or must there be certain conditions that accompany the metabolic syndrome?
Yeah, great question. Thank you. So the last together. So what we now understand is that inflammation almost anywhere that is chronic and severe has an impact on blood vessels. And when I was a student, we learned that atherosclerosis and ischemic heart disease was like a problem of clogging up a pipe. So there was all that cholesterol and all those fats and all that thing basically, so blood. What we now understand is the process of atherosclerosis is an inflammatory one. So the blood vessels, yes, do get clogged, but it's because the lining of the blood vessels, the epithelial cells involved and endothelial cells are getting inflamed. So rather than a pipe that's blocked, it's more like dermatologist, it's more like bad acne. Lots of inflammation clogging things up. Now the question is, what type of inflammation? So chronic skin inflammation, yep. Chronic joint inflammation, yep. Probably chronic bowel inflammation can add to your load of risk for heart disease. You almost certainly need to have other predisposing factors, probably genetics, diet or smoking, all those things contribute. But in fact, it's inflammation that drives this, not pure obstruction. So if you have something like metabolic syndrome, that occurs when people have things like insulin resistance and obesity and weight problems. Well, guess what? Fat cells, which when I was growing up as a student, we were taught as basically a receptacle for fat to be stored. Fat cells don't just do that. Fat cells talk to the inflammatory system, and fat causes inflammation in some patients. So it's not just about a higher BMI or having deposition of fat in certain areas. It's about the activity of those lipocytes with the increases. And you see this in some other diseases where if patients lose weight, their inflammatory disease gets better. And you can see that in a condition called hidradenitis, which is a horrible skin thing. You can actually see it in psoriasis as well. And you can see it in some of the inflammatory joint diseases. So it's a really complex problem of this interaction of inflammation anywhere in the body, the endocrine effects of metabolism. So you also see things like non-alcoholic disease, and trying to then work out where the connections are. Now, it doesn't work for everybody. You switch off the psoriasis and they don't have a risk of heart disease. If they still smoke and have high blood pressure and have a family history, it's not going to get rid of that. But it is all interlinked. That's not a very good answer. That's about where we are with the knowledge at the moment. The other question about UVB. So, ultraviolet light has a variety of different wavelengths. Remember physics and wavelengths of light? So UVA and UVB can affect the skin. UVC, doesn't get to our skin. UVA, slightly different wavelength, has a significant effect, on the immune cells in the skin. So you have an immune system that runs around your skin and nowhere else. Its job is to be on the lookout for infection, bacteria, but also abnormal skin cells. So it's like a surveillance system because your skin cells turn over all the time. Look at skin that's lasted more than 65 years and it's still gone. And if you hurt yourself, you heal. So we're always making new skin cells. If you've had a lot of damage to your skin from sunlight exposure when you were young, that has an effect on the memory of skin cells to keep producing a good skin cell. Over time, it can start producing abnormal skin cells. And that's because other forms of sunlight affect the DNA inside the cell. Okay, so it's not very common. And normally your immune system can come along and spot those abnormal cells and get rid of them. That's its job. It's like a policeman. As you get older, or if you have a lot of sun exposure, the UVA paralyzes that immune system. So it gets less efficient. As you get older, anyway, it drops off. So you see more sunburn, more skin cancers in older people than in younger. So the problem is, could you just have a little bit of sunlight to help your psoriasis and not too much to cause skin cancer? So the problem with sunlight causing skin cancer is two ways. One is a big hit of sun that causes huge damage, so blistering sunburns. My skin type, too much sun, and you go red and you blister. That's linked to melanoma. The other thing that can happen is you just have chronic exposure that keeps causing more damage. And that's linked to outdoor workers and exposure on the lips, and people who smoke make it worse as well. So that's a more chronic problem. When you get the immune problem plus the abnormal cell problem coming together, you increase your risk of skin cancer. And that's where sunlight treatments can be a problem. So we used to use UVA because it does that to your immune system. And what's going on in psoriasis? It's an immune system that's out of regulation. But you saw a lot of skin cancer. So if you can't use very specific sunlight wavelengths that don't cause the damage, then you are looking at trying to use sunlight. So the problem with sunlight is it's like it's contaminated with all these other wavelengths and will cause damage. So all you can do is restrict the amount of exposure. So if patients with psoriasis get out in the sun all the time, they're at risk of skin cancer. But if they just do a treatment course, like say, usually about 4 weeks of regular sun exposure, maybe 6 weeks, that'll make a big difference. So if you only do it intermittently, you reduce your overall dose of light and make skin cancer less of an issue. It's not an issue, but it's reduced. So protecting when they're in the sun for other reasons is important, but then saying 5 minutes in the morning, 5 minutes in the evening, not very much at all. Don't need much. 5 minutes is 1 cup of coffee. So tell them not to be out all the time, but to do it on a regular basis for a prescribed period of time, maybe a month. Okay? Does that make sense? Sort of. We have this problem with patients in Australia all the time because they know that sunlight makes them better. So they go out all the time and get very sun damaged and have a high rate of skin cancer. So it's really explaining to the patients that they might think it's great to do it all the time, but it's not a good idea.
One last question.
Oh, yeah. Oh, that's right. Sorry. So if you look at the prevalence of metabolic syndrome in patients with psoriasis, it is actually pretty high, and it might be around 30% or so. Depends a little bit on the populations as well. So children, not so much. Well, that's certainly adults. If you turn it the other way around, not every patient with metabolic syndrome has psoriasis. So obviously there is an overlap in that predisposition. So the genetic factors for psoriasis are really important. And psoriasis was the first disease associated with HLA. C, that HLA, you know about HLA. So human leukocyte, exactly. So there are different types of HLA disorders, and psoriasis is associated with HLA-CW7 subtype. And genetically, there are at least 10 genes that you can find in patients with psoriasis that may be transmitted through families. Having the gene is not enough to give you psoriasis, but you need the gene to get psoriasis. So a lot of people may be walking around with a genetic predisposition to psoriasis, but they don't get it. And probably because they need a specific trigger in their immune soup to turn it on. So you may have disease gene, but never manifest symptoms or the metabolic syndrome or the other factors. Really seem to play. So it's worth looking in patients with they have skin disease, but you certainly may not find it. But in the psoriasis patients, you should definitely look for it. Does that sort of answer your question? A bit.
It's sweet. Any more questions?
I think that we only have time.
Do you have any questions? Well, everyone, let's close the session. Yes, firstly, we are going to thank you. It's a pleasure for having you here. Thank you for sharing so much with us. And if I can conclude, psoriasis is a skin disease, but it's important for us to understand that it is not only a skin disease, but it is a skin disease. It is a skin issue that can put our patient in danger. Therefore, as a future doctor, we have to remember the clinical features, identify the issue, as well treat them accordingly. Thank you, Dr.
Well,
Give one more round.
meeting you over the next few years when you come to the clinics as well.
Amin. Ingatkan bersama kami.
Ow.
Yeah, thanks.
today. And for the fun Q&A section, sorry. We will go up. And for those who haven't give their question yet, I'm sure it's because we understand all the materials here. Thank you. Here, the documents, and it's
Photograph.
okay, and for our photograph as well. Okay, from for the participant, you guys can stand up. So
We're gonna do this. Okay.
Lebih baik ke depan ya? Baik di depan atau di
Okay, so I'm tall, so small people need to be in front.
guys yang agak pendek. Oke,